My name is Mashadi, and today I'll be, as mentioned, your guest speaker. So I'll be talking about the pre-medical journey, as well as, if we have time, the heart, which is my area of interest. So I'll be giving some intro of that. So before we go on to the agenda, if we can just, I'd like to get to know everyone. So if we can just go around and state your name, what career you would like to do, and if it is medicine, specialty of interest. Let's start over here.
I'm Chloe, and I want to go into biomed.
I'm Hannah, and I want to go into forensic pathology.
I'm Geneva, and I'm not really sure what something STEM.
My name's Millie, and I want to do something in the medical field.
My name's Gabriella, and I'm kind of undecided, but I want to do something medical.
I'm Grace, and I want to go into cellular bio.
Ryan, something engineering.
My name's Olivia, and something in STEM.
My name is Abraham, something medical.
My name's Karen, also something medical.
My name's Rose, and something in engineering.
I'm Lorraine, I'm not sure.
I'm Ranger, probably a veterinarian.
And then probably biology.
I'm Lulu, something medical.
I'm Julia, something medical.
I'm Nessa, something STEM.
Nice to meet you guys. Everyone has the right track, right? Everyone's doing well, everything, vet, STEM, all that stuff, very good. So an agenda, quick agenda, and I'll let you guys know this is the fourth class, so my voice is dead by now. I've been screaming for like 7 hours actually. So yes, if my voice is dead, if it sounds deceased, please forgive me. So I'll give an agenda. On next slide, I'll be talking about who I am and why I'm here and all that. Following that, I will be talking about the pre-medical journey, which is what the main stuff is. And I really want today to be a question-answer session where you guys can ask all your questions about medical school and such. So I'll be breaking into the academics. I'll be showing you what I did personally for my major, as well as the extracurriculars that I've been involved in. And then finally, if we have time, which hopefully we do because I enjoy this stuff, the heart. I'll be talking about heart anatomy, cardiac anatomy, basics, as well as congenital cardiac surgery, which is cardiac surgery oftentimes in kids because they were born with some kind of a defect in the heart. And I'll preface a disclaimer. The congenital cardiac surgery part will include real surgical footage, so if you don't like blood, I don't know what to tell you. I can have you step outside or something or look away, but it'll include blood. Like American Psycho, right? We're going to go American Psycho, all blood everywhere. Jokes. Okay, who am I? My name is Mashadi. I'm a recent graduate, put that in air quotes, because I had my last class on Thursday and my commencement's in 2 weeks. So technically I've done all the classes and hopefully, which I'm pretty sure, I'll be passing OChem lab, which is the last class I needed to do. So graduate from the University of Minnesota with a Bachelor's of Art in Human Physiology and a minor in Urdu. Urdu is a language primarily spoken in India and Pakistan. I'm Pakistani, so I was like, why not get better at mother tongue? So I did mine in Urdu. I also graduated from Wayzata High School back in 2019. So I was literally in your seats a couple of years ago, only 4 years ago. I was a student in Miss Layden's biology and human anatomy class. This is your class, right? Not Miss Layden's? Mm-hmm. Who's had Miss Layden, though, for biology? I loved her. She also wrote me a letter of rec for college. She was the best teacher I've had. But, why did I come back? And the reason why I'm standing up here today is because Miss Layden and her human anatomy class was very integral in my interest. I'll go as far as saying love for medicine. And so this is my story. When I was in 11th grade, I was in Miss Layden's human anatomy class, and I was sitting there and everything, and during that time, my uncle, he was about 50 years old, he resides in New Jersey, he was born with something called a PFO, patent foraminal which is a hole in your heart. And so, he lived until 50, he was doing fine, everything, but he thought, well, I'm not getting any younger, right? If I want to live a long time, right, 89 years old, I'm going to have to get this fixed. And I'm only going to get older, and if I get older, then perhaps the surgeons won't be able to operate on me because of my age. So he said, okay, I'll consult with the surgeon, and I'll get the defect fixed. He consulted, the surgeon said, yeah, I'll fix your heart, I'll fix the hole in your heart. And while I'm doing that, you've accumulated some artery disease, coronary artery disease, from cholesterol and all the foods we eat, everything. So he said, while I'm there, I'll just do a coronary artery bypass, and so that you're going to be all set, you're going to be all good. So that was scheduled, it was all set. And, unfortunately, the surgery, there are some complications. And I remember that day, it was actually the night, I called my father who went to New Jersey to be with his brother-in-law. And I called and I said, hey, how's the surgery? Is it all good? And he was like, well, they just finished. It's been 12 hours. And with the little medical knowledge I did have, I was like, well, 12 hours, that seems like too long. There must have been something wrong, Even for any kind of procedure, 12 hours is like stretching it. So I knew there was something wrong. And, I was right. My uncle, he was very sick. He was in the hospital for 50 days. He went all the way, he turned to kidney failure, which is, for those maybe dialysis, anyone heard of dialysis before? So that's what happens. You're on dialysis, if your kidneys are failing, they're injured, they start to, you need dialysis. And so he deterred all the way there, and it was looking bad. His prognosis, his outcomes, it was not looking good, We were all prepared for the worst. But fortunately, he recovered, and now he's sitting in New Jersey, I always call him and joke around, and he's completely fine. But during that time, coincidentally, actually, we started the heart anatomy section of the class. And so while hearing all this stuff, and my uncle, getting worse and worse, I was able to learn, okay, what is the defect that he did have? What went wrong? Right? Also questions such as, who does this type of procedure? What kind of doctor does it? Realizing that, cardiac surgeons do it. Looking at, how long does it become a cardiac surgeon? All those different things. Also having the fortune of having a family friend who's a cardiac surgeon, being able to ask him questions. And so 5 years ago, in 11th grade, that interest of, medicine and stuff, it became now a full-grown love for the heart. And, since then, over the past 5 years, my interest and love for cardiac surgery has grown through different experiences I've had. And so that's why I'm here, because who knows, perhaps maybe there may have been a past experience, a present, maybe future experience for you all, that same thing might happen, where you just fall in love with something, and that, this is a career for me. So that's why I'm here. I'm here to let you guys know about some stuff, and hopefully, maybe get some more doctors to be physicians practicing. So, any questions actually before about who I am? Any introductory stuff? Okay, sounds good. Okay, next I'll be talking about my academics. So, I did PSEO during my senior year at the University of Minnesota, and in quarters 1 and 2, I did physics here, and then I did 3 classes at the university. General chemistry 1, I'll highlight, the teacher was terrible. The teacher was horrendous. The average was like a C+. And, as you guys will probably learn, actually, who's a senior in here? Yeah, there's one senior? One senior, okay. Well, everyone else is a junior then, I'm assuming? Juniors, okay, so you'll learn very quickly that at big institutions, like for example the University of Minnesota or Madison or something like that, very big, they are research schools. And so the professors, they sometimes are offered positions because they're excellent at the research they do in their field, but they're sometimes not the best teachers. And so in this case, that my Gen Chem teacher, Gen Chem 1 teacher, it was evident that he was hired because his research is very good, his teaching skills were not. For example, Saint Benedict, right?
St. John's.
St. John's. St. John's, I believe it's a liberal arts school.
Mm-hmm.
So that those teachers are probably going to be way better at actually teaching you knowledge. So you're all good, you know. You're all good. You won't have to suffer the sitting there in class of someone just rambling about some random stuff and making an exam so hard that no one will pass. So you won't have to worry about that. But I took Gen Chem 1 in the lab as well as history class in my fall PSEO year, and then in the spring I chose to do all my classes at the University of Minnesota. So I did microeconomics to get rid of that requirement as a high school student. I did an English class, I did another history class, and I did math, pre-calc 2. And you know, just like I said that teacher was terrible, my pre-calc teacher was amazing, on the other hand. And it was quite evident that she was hired because she is great at teaching. She is a really good teacher who actually cares about the students and who can actually relate to them and give them knowledge. So following that, I started at the University of Minnesota. In my fall semester, I did General Chemistry 2. Again, a great teacher. I liked my Gen Chem 2 teacher. And I did the corresponding lab to that. Then I did a seminar. This is just a typical, welcome to college, how are you doing, that kind of stuff. Future Physicians class, which is a seminar, and I'll be honest, I didn't go to the class because it was very, very basic stuff. What is a physician? What do they do for a living? All that stuff, which is like, I already knew it, so I was like, well, I'd rather take my time and do something else. I did all the quizzes and stuff, and it was a seminar, a very easy class, basic, all that. So it wasn't that hard, but I did that, as well as starting my minor in Urdu, with beginning Urdu 1. And then spring 2022 or 2020 happened. COVID is everyone's best friend, COVID-19, right? Everyone loved that. So I started doing online classes because of COVID. My general biology, as well as the second set of the CLA class, or the seminar, and then again, beginning Urdu, second edition. Transition to my sophomore year. This was all online, sophomore year. So, in my summer, I did organic chemistry. Who's taking organic chemistry? No one? Excellent. You guys have saved yourself. I hated organic chemistry. Like, I'm not going to lie, sit here and be like, it's the best. No, I do not like it. It was not the best. Who taking Calc AB? Taking Calc AB? You guys liked it? You liked it? It's fine. I don't like Calc. Okay? I don't like Calc. So my summer was, I would say, very fun, right? Very fun. 2 classes that I don't really like that much. But I did it. Then in the fall, again online, I did 2 classes to fulfill my minor in Urdu with concepts of Asian and Middle East studies, as well as modern Indian literature. And then I also did biochemistry, which was the first class that I found relevance to in terms of the human body, because you have to have an understanding of like the biocarbonate buffer, which is how you regulate oxygen and stuff. Why you breathe, respiration goes up and down. That's what that buffer is called. So learning about that as well as other things, understanding why do drugs work a certain way and the chemistry around that in the biological sense. I then took Organic Chemistry 2. Again, my favorite, organic chemistry, right? I did not like that either. No surprise. I did my intermediate Urdu, again my minor. And then in the spring I did applied biostatistics. That was a fun thing, I enjoyed it a little bit. But I'm not the coding type, so I wasn't the best at the class, but I still did good in it, so that's all that matters, right? You just have to get a good grade. Get an A in it, it doesn't matter if you like it or not. And I did Physics 1. Physics 1 I liked because I felt it was better than Physics 2. Physics 1 talked about fluid dynamics and all that, so I could relate it to blood flow. And I was like, well, okay, I can apply this to my actual life and see the effects of it. And then I did Intermediate Urdu 2. And then my junior year happened. That's when we moved in person again. I did Physics 2. I didn't really like it that much. Talking about currents and stuff, I couldn't really relate it to my life. And then my fall, so my junior year fall, I did genetics, physiology lab, and advanced Urdu. And then in the spring, I did physiology of bionic human. And you might be looking and thinking, bionic human, that sounds cool, right? That's the same thing I also thought. Sounds cool. Who's heard of an LVAD before? Left ventricular assist device. Couple hands. What can you tell the class what that is? In your understanding?
No, I don't like stuff.
Yeah. Do you know what type of patient would get an LVAD? Yes, you are spot on, right? Spot on, okay? Let me drink some water quickly. So an LVAD is basically is people that are in heart failure, right? And so oftentimes in the current research, they're looking at LVADs in heart transplants. They're very comparable in terms of outcomes. And so as everyone knows, and it's an issue worldwide, which is that there's a limited amount of organs that can be transplanted, but there's a lot of people on the transplant list. And so of course there's innovations and stuff, technology is advanced and devices are being made so that they can mitigate that shortage. And so bionic human is just about that. We talked about the different devices that are being used in day-to-day life to help with organs and such. And the class is also unique in that it was half biomedical engineers, half physiology majors. And so it's something where I could call one of my biomedical engineering friends in the class and be like, hey, like in 20 years, be like, hey, this patient's presenting like this. Can we come up with a device to make sure that this problem is fixed? Right. So it was a very unique, interesting class, and I enjoyed it. Bionic human, it was a very good class. And then finally, my senior year, which has been this past year, I did a capstone in my summer. The capstone was about a neurosurgeon that is actually practices in Minnesota. Who's heard of concussions? Who's a fan of the NFL? Okay, so a big thing in the NFL, as some people may know, is concussions. And the problem with concussions is that it's very hard to diagnose. There's no definitive way to look at someone and be like, hey, this person has concussion. Right? And that's one of the reasons why, I asked about the NFL is, Tua, concussion, like every day concussion, right? Banging his head on everything. I think that was one of the reasons why. I think, personal opinion, I believe that he was put into games because well, they couldn't diagnose it with a concussion. There's no definitive way. And so this neurosurgeon did, was she made a device, which is, it looks at the eyes, right? And they found that with the eyes, when someone has a concussion, their eyes move in such a way that it's like, well, okay, from these results, this person has a concussion or not. So I wrote a paper on her. I wrote a paper on her research. And that's what my capstone is about. And then in the summer also I did problems with physiology class, which is just getting credit for my research. So you'll see the same class come over and over again for my senior year because I was just getting credit for my research. In the fall, I did cell biology, culture, identity, and precision medicine, which is just a class talking about cultural competence in medicine. And then I also did an introductory neuroscience class, which I loved. It was a very nice class. Again, probably physiology. And then this past spring, just finished on Thursday, I did organic chemistry lab, which I absolutely hated. Worst class of my academic career. It was terrible. And I'll tell you guys a story about it. So, the teacher made the grading rubric in such a way that if you asked your TA a question during lab, you get deducted points. So if you were like, asking something, you get deducted points. And this is not a class that you're working with stuff that it's not going to hurt you, like water and stuff. No, you're working with strong acids, strong bases, open flames, the whole 9 yards. All right. I even cut my hand on glassware. Like, it was hazardous, right? And the thing is, if you were to ask a question, hey, okay, deduct point. I'll leave -1. So that happened. Additionally, the first day of class, right, walking in, I was like, as in other classes, first day, they hold your hand a little bit. They help you out. But no, this class was straight, like, dive in, okay? And we did some experiment. We were working with strong acid. And the countertops in the lab are just like this. They're black. Those who have experience, if you put water or any other liquid on the black countertop, it looks exactly the same. So what happened was we were working with strong acid. I must have allegedly put some acid accidentally on the countertop, spilled some. It looked like water. I thought it was water. Hand to heart, I thought it was water. Teacher came over because, it looked like I was struggling, which I was. He put his hand on the countertop and immediately he put his hand up. And he said, Ali, was that water? And I was like, yeah, it's water. Like, what are you talking about? Immediately, right when I said that, he ran to the sink, full glass water, put his hand under. He's like, well, it doesn't feel like water. It doesn't feel like water. And I'm like, shoot, right? I'm going to have this guy grading my lab reports, grading all my assignments for the rest of the semester. And I just chemically burnt him on the first day of class. Excellent. Right? And I was like, this guy's going to deduct points for nothing. That hypothesis was correct. He did deduct a lot of points. And, he says it's not because of that. I think otherwise. Right? But that happened, right? And thank God it finished on Thursday. And I kicked my books for that class away. I burnt them. And I'm like, all the stuff I knew, finished, right? So, finished that class on Thursday. And problems with physiology I also did this past semester. Overall, you might be looking and being like, well, Oli, you did 1 year PSEO and 4 years of undergrad. Typically, isn't it 4 years of, to finish a degree, 4 years of college? Yes, that is true. For most time, it's 4 years. And my 5 years here, it goes to the topic of reduced course load versus graduating early. So I know a lot of my friends that did PSEO, they graduated college at 19, 20 years old. And the reason why is because they did PSEO. They finished very early. Me, on the other hand, I was like, well, I want to do medicine. And for that, I know I'm going to have to do a lot of extracurriculars. So I'm going to take a reduced course load instead of taking, the 16, 17, 18 credit courses or loads of classes each semester, I'll take maybe 13, 14, and I'll reduce it a little bit so that I can do extracurriculars on the side as well. And then finally, before we'll have questions, because I need questions. My voice is dying. Like tomorrow's gonna be amazing. I'm gonna be walking up. Hello, how are you? It's gonna be amazing tomorrow. But okay, last thing is BAMD, BSMD, BSDO, BADO programs. Who's heard of those? Anyone? No. That's okay. I was just like that. I was like, someone said that, and I was like, what the hell is that? Right? Well, what are you talking about? So what that is, these are programs that you gain direct admission into medical school from high school. And it's good we have, actually I'm saying this because we have a large class, I think only one senior, large class of juniors. So you guys still have a chance to look into this if you're interested in medicine. So this is where you get direct admission in medical school from high school. You have, these programs have certain requirements. You have to have oftentimes certain major, you have to have a certain GPA, MCAT, you have to do certain extracurriculars. But you're in medical school. If you do those, you're granted acceptance in medical school. Luckily, I've actually had the fortune of having many friends in these programs at the university. And so the first question, of course, anyone would ask, okay, I guess some knowledge. At the university, there's probably in the program 10 people each year that are selected out of like 40,000, right? So they're very, very selective, very few people in these programs. For obvious reasons, you get right into medical school. But I asked them, what did you do in high school to get accepted in this? Like, I thought I was cool, right? I thought I was cool, but you seemed to be cooler. You had a lot of other stuff. And so I'm not going to lie and sugarcoat it and say, no, they were just like me. No, they had the S tier kind of stuff. Their GPA was very good. Their SAT, ACT scores were tops of the tops. Extracurriculars were also amazing. One of my friends founded a company in high school. And so, exactly, that was my reaction. What? Right? And so, I'm not saying that if you don't found a company, you don't have the best ACT, best SAT, best stats, that you're not going to get accepted into one of those. But at least from my experience, the type of kids that got accepted, they did have the full, package. And to be quite honest with you, those kids that do get accepted in those, they're the type of kids that are going to Harvard, Yale, Columbia, those Ivy Leagues, right? And the reason why, and it makes sense, right? The kids that would go to one of those big schools, right? Those nice nice universities, they were most likely would also get accepted into like a top tier medical school. And so, like my friend, for example, that founded the company, he got accepted to Harvard, but he elected to come to the University of Minnesota. So, it's one of the things where, it never hurts to try. Definitely try and see if you can get accepted to the programs, but yeah. There's also several former Wayzata High School students that have been accepted to these programs. I know a couple years ago, two people, I think 2 girls got accepted, and then maybe 3. So a lot of students do get accepted from here. Here's a list of these programs, locations. You'll see it's kind of a little outdated, 2021, 2022. But yeah, these are the schools. Usually it's a 6 to 8 year program. Where, for example, the University of Minnesota, even though I see right now it's listed as a 6-year program, that's wrong. It's actually 7 year. But you do 3 years of undergrad and then you do 4 years of medical school. So yes, any questions? Any questions that you have for me about anything that I've said so far? Please ask questions. I swear my voice is gone. Yes.
So what type of extracurriculars would you do?
What's your name?
Abraham.
Abraham. You know, you're right on par because actually the next thing I'm going to talk about is extracurriculars. So I'll table it for like a couple minutes and then I'll talk about that. Yes.
Since you graduated, now are you doing any schooling like next year, or are you going right into?
No, so I will be taking a gap year. So I'll actually talk about this. Now hopefully I'll be doing some research in cardiac surgery. Anyone? Any more questions? Yes.
Do you know, I know you kind of really got interested in the cardiac area when you were in high school and with your uncle, but did you know right away that that's like what you wanted to do in medicine?
Definitely not. This is actually a question that was posed a couple of class periods ago. Cardiac surgery, to be a full-fledged cardiothoracic surgeon, it's a long time. I'll just tell you guys, so 4 years of undergrad, 4 years of medical school, probably 6 to 8 years of residency, and then you do your fellowship perhaps. And so I think I calculated myself, I think I would be like mid-30s by the time I would finish. For some people that's definitely not, like they're like mid-30s, like hopefully I'm in like LA doing something, right? I'm like a movie star when I'm 30. But for me, to answer your question, when I did my research, I found that's how long it took. I was very resistant. I was like, I don't want to do that. Like, it's too long, right? And who knows, right? Who knows if at the end of however long, I still want to do it. But then ultimately, my experiences after high school, and as well as kind of looking at stuff and doing that, I like it a lot still. And ultimately, this is just I guess a message. You should do something because you actually enjoy it, because you're gonna have to do that for a long time. That's your profession. Cardiac surgeons, I'll give you guys this stat. There's a recent survey done on all physicians in terms of salary. Cardiac surgeons make on average $700,000 a year. To a lot of people, that's to a lot, not a lot. To most people, to everyone, that's a lot of money, right? $700,000, right? And so obviously, people look at that and like, oh, I want to be a heart surgeon then. Ultimately, though, the reality of it is, if you're being a heart surgeon, you're waking up at 4 a.m., you're going home, you're finishing the day probably 8 p.m., and you're on call a lot, meaning that if you're at a birthday party and someone's coming in, they need a transplant, you'll leave the birthday party, right? That's your life. For me, in high school, I was like, I don't want to do that. But now I've kind of accepted it, like, if this is something I love, this is what I really want to do, I'll do it. Because to wake up in the morning and to do something you don't enjoy, it's not a way to live. Any other questions? Let me ask you guys this. So if you wanted to go straight through into medical school from undergrad, when would you take your MCAT? MCAT is like the ACT for medical school. It's like the admission exam. Okay, so I see two groups. I heard two groups. What do you guys think? When did you take your MCAT?
Prior junior year.
Junior year, yes. You're correct. So, it's just like college admissions in that it takes a full year for you to find out where you go. And so, application cycle opens around like May, June time. So you would take your MCAT probably like April of your junior year going into your senior year, and then apply for that upcoming cycle that you get accepted right away. Any other questions?
What's fellowship?
Fellowship. Excellent question. Okay, does anyone know what residency is? Anyone familiar with what's residency?
It's like when you're like sort of working as
Excellent. So residency is in training. You're training to be a certain specialty, right? So you have your degree, you went through medical school, but now it's like, okay, you've learned a bunch of stuff in school, but now it's how do you apply it in the real world to treat a patient? That's what residency is. Fellowship is further specialization. So an example is like a lot of people, they do internal medicine for a residency, which is about 3 years, 3 or 4 years. And internal medicine is like, it's like the general practitioner. They see everything. They see like, okay, you come in with an injury to, or you come into the hospital with certain condition, and they help you with that, right? Fellowship is like if you want to do like cardiology or something. So it's further specialization. I'll put it like that, further specialization. So you're still training, but you're just further specializing in a certain area. That's what fellowship is. Any other questions? Yes.
Will you be able to perform all types of heart surgery, or is it limited to a certain category or something?
Excellent question. So it depends. I'll tell you that. Some heart surgeons, they further specialize. They do like a fellowship, sometimes super fellowship. They further, all the furthest away, specialize into something like, I'll give you an example, like heart failure. So they're only doing heart transplants. Other people, like surgeon I work with, in the next slide you'll hear about that. He's a congenital cardiac surgeon. So he did his surgery, cardiac surgery residency and fellowship, and they further specialized in treating kids. So it also depends on if there's a lot of other cardiac surgeons with you. You might say, okay, I'll do this procedure, I'll do these types of things. Another person does this. But if you're the only person in, as like I know, my family friend, he's the only heart surgeon in like 100-mile radius. So anyone who needs heart surgery, he's the go-to person. So he has to learn, he has to know how to do everything. So it depends on different variables. Any other questions? All right. As, was it Matthew McConaughey? All right. I don't know. Extracurriculars. So on extracurriculars in high school, it's emphasized do X, Y, and Z. They also matter for medical school. And typically you have your volunteering, your research, your clinical exposure, etc. And many of them also can fall into a variety of different categories, and so you can double dip. For example, in my case, my research is also clinical, so I can get clinical exposure during my research. So there's double dipping in those two, for example. I'll also give another example of my journey, of this double dipping concept. You should also do things that you actually want to do, not just to check off a box. So if you really hate research, you should not do research for 4 years, right? You should do things that you actually want to do, because ultimately admissions can tell. You've all probably sat with someone who does very cool things, and you talk to them and they have no emphasis in their voice, and you can obviously tell, yeah, this person, they were forced to do it, they actually don't like it. Versus like, on the contrary, you sit with someone who actually wanted to do something and they really love it, you can tell, because they're like all over the place, all bubbly and happy about it. So admissions can tell as well if you actually like what you're doing or not. My extracurriculars, I've done 4 years of research, and so I did, again, I did PSCO, and so right out of PSCO, out of high school, I started doing basic science research, which is, basic science is like research on minute stuff, meaning like proteins and different, like microfilaments, things that make up a larger thing. I think you guys have learned all these stuff, yeah, so like that, that's basic science. And oftentimes it's done on an animal model, so like mice or rats or like hamsters. I don't know if hamsters are used, but something like that. I did that for about a year and a half with the Dr. Dwayne Townsend. He's a PhD. I was his research assistant in the Department of Integrated Biology and Physiology, and we studied the effects of Duchenne muscular dystrophy on the heart. Who's heard of Duchenne muscular dystrophy before? Would you like to tell what is Duchenne muscular dystrophy?
I can try, but it's
Okay.
just basically like breaking down the muscles. I think it mainly affects like males, and
Yes.
yeah, it just like it leads to early death as well.
Yes, why? Why did you say typically males? Is there a particular genetic
I think
reason?
it's probably linked to the X chromosome.
Excellent, yes. Have you taken genetics? Or nothing?
No.
No. Well, that's an excellent explanation, yes. It's X-linked recessive disease, and like you said, it causes a lot of bad stuff, right? And so one of the things it causes the heart damage. So I studied that, and probably from my description of that, you can probably tell it was not my style. I know basic science, for some people, they really enjoy it. For myself, I like reading about patients and learning about different people, right? And ultimately, this wasn't something that I would wake up in the morning and be like, I want to go to the lab and study this. And so I didn't really enjoy it that much. On the other hand, though, I found clinical outcomes research is what I really enjoy. And that's what I've done for 2.5 years, and I'll continue to do in the future. With a doctor named Dr. Sami Saeed. He used to be at the University of Minnesota. Now he's transitioned to Westchester Medical Center in New York. He's research fellow in the Department of Pediatric Cardiac Surgery, and you study outcomes of congenital cardiac patients, so patients that are born with some kind of heart defect. And I love this. I enjoy it, and I think that I'm going to continue to do this for the rest of my life, right? I'm going to continue to do some sorts of clinical outcomes research for the eternity. Additionally, additional benefit is I've been able to have some publications in it. So I guess that's another thing that medical schools, or once you're in medical school, they look at publications and stuff. I've been able to amass some of those. I've also done shadowing, 4 years of shadowing in CT surgery, for example. Began as a rising freshman. Again, right after I finished high school, I went first time to the operating room, and I saw my first open heart surgery, which was actually coronary artery bypass until an adult. I've also seen LVAD, left ventricular assist device, in an adult, Mays procedure, which is for atrial fibrillation, in an adult, Samatar syndrome repair, done on a child, 6 years old. An ASD, atrial septal defect closure, also done on a child, and many other things. I've also shadowed in the ICU. The tamponade story is, tamponade is basically where you have fluid surrounding your heart, and you can think of your heart sits in like a balloon, right? And so if you can imagine, if you fill the balloon up with a bunch of water, your heart will be able to pump. So that's what tamponade is. Fluid fills around the heart, the sac that the heart sits in. And so in this case, there was a patient that had just received a heart transplant, and he developed tamponade. And so they were able to take him and remove the blood from around the sac surrounding his heart, and he was doing well. In terms of leadership, I have also done some 3 years of leadership. I founded a group, and I was a founding president of the group, something called Multi-Potentialized in Medicine, which is for students that are interested in clinical practice, as well as another discipline, such as research, policy, public health. How did this start? Well, it was actually a late night phone call with one of my friends, and we both expressed interest in doing business in medicine, possibly maybe making a clinic or something. And so we started talking. We're like, wow, we have the same ideas. Let's see if other people also have an interest in this. And they did. And we were able to assemble a team in 2020, and we got started. And during this time also was when I was doing research, basic science research, and I wasn't liking it that much. And got involved in a journal club. It was also during COVID. So on LinkedIn I found, it's on TikTok actually. I was on TikTok one day and it came an ad. Do you want to join a journal club for neuroscience? And I was like, shoot, okay, sure. So I opened up my LinkedIn and I got added to the group. And I did that in summer 2020. And from there I found that there's something called clinical research, outcomes research. And that's when I was like, wow, this is really cool. I really like this. And that's what led me to reach out to Dr. Sami Saeed and fall in love with the idea and career trajectory of academic medicine, which is where you do clinical practice, of course, with research, teaching. I also like teaching. This is why I like to do this kind of stuff, teach people stuff. So, yeah. Also, this group recently won an award at the university for career readiness. I've also been associated with Pak Science Student Association at the university for 2 years. 1 year for outreach coordinator, and then this past year I was elected president of the group and served as their president. Teaching, I've taught for a year. I was a TA for genetics, as well as I'm a mentor in the Big Brothers Big Sisters program, mentoring a 4th grader. So, like I said before, this double dips on Big Brothers Big Sisters activity, and that you can say teaching as well as mentorship, and so you can see multiple different events can be combined together. Volunteering, I volunteered at HCMC Hennepin County Medical Center for about a year. Yes. Any questions about extracurriculars? As you can see, my voice is gone at this point. Any questions? Shoot, it's actually gone. Wow. I did not expect it. Okay. Any questions at all?
Which extracurricular that you did you think was the best, and then what one was the worst use of your time?
Yeah, the research, clinical research that I do, I think that's the best. I enjoy it. Waste. I don't think anything wasted. I think it taught me something. So I don't think I've ever done an event or done an activity I really was like, this was a waste of my time. But it's definitely, everything has taught me something. Yeah. Any more questions? Yes.
Were all of the extracurriculars you listed during college, right before? Did you do anything in high school before?
In high school, I was YES. I remember doing that at with the Park Nicollet. I volunteered there for 2 years. Trying to think. Yes, I did stuff. I haven't included in any of that though. So this is all during my 4 years of college. Any more questions? Okay, you're checking the watch.
Oh,
I was
sorry.
okay, we'll start talking about the heart. Okay, luckily, usually it's 10 minutes. You guys have a lot. Maybe I was talking fast, or maybe, I don't know, you guys are just tired. But thank God, okay? There's a lot of videos now. So we're going to first talk about the heart and blood flow. And by the way, this person narrating, she's British, which I like the British accent. I'm just gonna say that. The British accent's cool.
This animation illustrates a single cardiac cycle, starting with the right side of the heart. In reality, of course, the two sides of the heart work together at the same time, but it is easier to understand if we look at them separately, because each side of the heart has a different function. The cardiac cycle begins as deoxygenated blood flows from the body into the right atrium via the superior vena cava and inferior vena cava. In the next phase of the cycle, the right atrium contracts, pumping blood into the right ventricle through the tricuspid valve. Once the right ventricle fills with blood, the tricuspid valve closes to prevent blood flowing back into the atrium. The right ventricle contracts, forcing the pulmonary valve to open as blood is pumped into the pulmonary artery. Blood then travels to the lungs and the pulmonary valve closes. At the same time, the right atrium relaxes, ready to accept the next intake of blood. In the lungs, lungs, the blood picks up oxygen and releases carbon dioxide. Oxygenated blood flows from the lungs into the left atrium via the pulmonary veins. The left atrium contracts to pump blood into the left ventricle through the mitral valve. Once the left ventricle has filled with blood, the mitral valve closes. Next, the left ventricle contracts, forcing the aortic valve to open, allowing blood to be pumped into the aorta and from there around the body. The aortic valve closes to prevent blood flowing back into the left ventricle, and the left ventricle relaxes, ready to accept the next intake of blood. Cardiac cycle is now complete.
Okay, so hope you guys liked her accent as well as I did. But now it's, you've heard it, but now let's go through slowly. So the atrium and ventricle. Okay, so there's a difference: the right atrium versus the right ventricle. Right atrium versus left atrium. So the right atrium, as you guys can see, and I'll also tell you guys, to see this anatomically, like in surgery and such, you have to open the heart up. So you have to, cut it open or something in order to see this stuff. But the right atrium is where colloquially is called bad blood. And why is it called bad blood? It's not bad. It's not like evil. It hasn't committed a crime or anything. It's just deoxygenated. Well, other than the left atrium, that's where oxygenated blood comes in. And you'll also see denoted in like textbooks and figures, the oxygenated is always red and the deoxygenated is blue. And that's not actually how it'll look. It's more of just a way to depict it. Those are the colors they selected, and that's actually something I learned from Miss Layden in her class. Was that it's not actually blue or red; that's how they show it. The right ventricle and the left ventricle, likewise. Right ventricle is deoxygenated blood. That's where it comes. Then it just pumps it to the pulmonary artery, and then it goes to the lungs in order to be oxygenated. And the left ventricle, oxygenated blood pumps the blood to the aorta, where it then goes to your body. Now the valves. Again, you'll have to open up the heart in order to see this, but your tricuspid valve, which is tricuspid in nature, all tricuspid means is that, as you guys can see like in this figure, it just has 3 segments, right? And so the tricuspid valve is between the right atrium and right ventricle. Your pulmonary valve, again, tricuspid, 3 segments, leads to the pulmonary artery. Your mitral valve is bicuspid. It has 2 segments between the left atrium and left ventricle. And finally, your aortic valve is tricuspid, again, 3 segments, leads to your aorta. Finally, this was actually not something talked about in the video, but it's another anatomical thing that you may hear, are the coronaries, coronary arteries and veins. And unlike the atrium, ventricle, and the valves, the coronaries are something you can see on the outside of the heart. You don't have to open up the heart, you just have to open up the chest, separate the ribs, and you can see the coronaries on the heart. And so the coronaries, so the heart supplies blood to the rest of the body, which is oxygenated. But what supplies the heart with oxygen? Well, those are the coronary arteries. And as you can see in the figure, there are a bunch of coronary arteries coming here and there. They have different names. The left coronary artery, right coronary artery, etc. And they supply the heart with oxygenated blood, while the coronary veins, they bring deoxygenated blood back to the heart. And so now I have a set of couple questions, and maybe we can have whatever table you're in, you guys can just talk. Which structure does deoxygenated blood return to? Is it A, the right ventricle, B, the left ventricle, C, the left atrium, or D, the right atrium? Okay, who is the brave soul, as they used to tell me, who's the brave soul that wants to speak up and give me the answer? Yes. D, the right atrium. Ding, ding, ding. Yes, correct. Very good. Next question. All these valves are tricuspid except aortic valve, the tricuspid valve, mitral valve, or pulmonary valve. Yes. Okay, discuss with your group. Which one is not tricuspid? Okay, who wants to answer? Yes, yes.
Mitral valve?
Mitral valve. Ding, ding, ding. Correct. Correct. Okay, now this is more of a trick question, but it's cool, right? And this is a 3D reconstruction, a CT, 3D reconstruction of someone's heart. Okay, this is the patient has this condition. A patient presents with anomalous left coronary artery from the pulmonary artery, Al Kappa, at birth. How will this patient present at 2 to 3 months of age? And I know this is hard. I'll give you guys a little bit of a clue. Think about what do the coronary arteries do. Okay? Is it A, are they normal? There's nothing wrong with them. B, are they taller than normal? C, are they blue, cyanotic, blue meaning cyanotic, aka shortage of oxygen? Or D, are they diabetic? Talk with your group. And okay, who wants to answer? Who thinks they know what Al Kappa will cause? In the back, what do people think? In the back. One of you guys in the back.
Come on, Ranger.
Ranger. Yes, Ranger. Yes. Okay, what do you think? What do you think?
What do you think? C. I don't know.
C. Blue. Are you sure?
Not sure.
You're not sure?
No.
Okay, who's sure? Yes.
I'm A.
A. Okay, they're normal. Al Kappa causes normal people.
Well, I haven't had time to affect it yet in 2 or 3 months.
Okay. I'll tell you, I think the Ranger is correct actually.
I think it's
Blue! They're cyanotic, aka shortest of oxygen. Okay, and first off, my sister, I showed her the presentation. She told me, she said, why you gotta do the baby like that? Like, but this is what cyanosis looks like, okay? You'll see blue.
Oh, that's sad.
And it's, it's blue baby syndrome. There's many different conditions that causes cyanosis. There's something called tetralogy of Fallot, which also causes cyanosis. So this is the common presentation in children with congenital cardiac defects. But this is what cyanosis looks like. They're blue. Okay, we have 15 minutes, 20 minutes?
Yeah, about 17, yep.
19. Excellent, right? Something like that. Okay, so we're going to talk about my research that I do, conditions and such. Okay, so my research is congenital cardiac surgery, which is cardiac defects which happen at birth. So the first topic is called chortriatriatum. Chortriatriatum is a fibrous membrane in the atria of the heart. Okay, and so it can either be, there's two types. There's sinister. Sinister, the membrane is in the left side of the heart, above the tricuspid valve, a mitral valve in the left atrium, or dexter, which is where the membrane is above the tricuspid valve in the right atrium. And the membrane can be obstructed, means that there's no holes in it. And these images, these are all unobstructed, but there's no holes in it. And so oftentimes kids that have this, it's noticed, right? Because there's no blood going to the ventricles. Additionally, there's other things. They can have an atrial septal defect that helps it so that it's not as noticeable, but still, if you have something chilling right above your mitral valve, it's going to cause an issue. Unobstructed, that means that there's holes. It depends on the degree. If there's a big hole, it might go incidentally. If they're smaller, it might be a little bit less. But these are incidentally found oftentimes, meaning that these kids or these individuals, they don't know until later in life when they have some echocardiogram and they're like, hold up, there's a membrane in your heart, right? Okay, so question: a 63-year-old patient is scheduled to undergo eye surgery for cataracts, which is a cataract is your lens is cloudy in your eye. As is routine, this patient undergoes an echocardiogram for cardiac clearance. A membrane is found to be existent in the left atrium above the mitral valve, consistent with cor triatriatum. Which type and obstructiveness would this membrane most likely be? Is it A, cor triatriatum dexter, non-obstructed? B, is it sinister, obstructed? D, sinister, unobstructed? Or D, dexter, obstructed?
Mitral valve is the left. Yeah, it has to be.
Okay, who wants to answer? Who wants to answer? What do they think it is? Who wants to answer? Anyone? People in the back? Anyone wants to answer? You want to answer? You guys want to take a guess? You know? Take a guess. Okay. So what do you think obstructiveness? How obstructive is non-obstructive? Why? Give your rationale. You guessed? Okay. Well, you're on the right track. It's not obstructed. It's non-obstructed. Why? Why? Who wants to answer? Give your hand raised.
Is it because he's 63, so like if it was obstructed, then he'd probably like not be living anymore?
Excellent. Yes. So the trick in this is that the patient's 63 years old, and so most likely it's incidental, because if it was obstructed, then it would be like, well, that would be noticed early. This 63-year-old, as well as you guys did good in that sinister, it's in the left atrium. So very good. The reason why this is an interest is because I had the fortune of publishing a paper in November of last year on cor triatriatum sinister, also the one in the left atrium, in the Journal of Cardiac Surgery. So a quick recap of the paper. There were 16 patients over 20 years at the University of Minnesota with a mean age of diagnosis of 4.3 months. So these children were very young. And so from that, we found that there was no real good classification system, and we ultimately were like, well, let's just make our own, right? If there's nothing there, let's just make our own. So we made one Mashadi's Narasimhan Sayed classification for cor triatriatum sinister. The link is here, as well as the table. You guys will hopefully get this on your Canvas site, my slides, so if you're interested in reading that. I'm going to skip this video and I'm going to do this one. Okay. So this is the actual surgical video. Soon, yes. Okay, so this is atrioventricular septal defect. So this is a malformation of the atrial and ventricular septums. As you can see over here, the normal heart. This is atrioventricular septal defect. And so you can see over here right away, the atrium and ventricles, the septum is gone. And additionally, there's one common valve rather than having two, which having one tricuspid, one mitral. There's a common valve, right? Because there's no septums. The incidence is about 0.24 to 0.31 for every 1,000 births, so that translates to 0.02% to 0.03% of people that are born have this. Additionally, there's a strong association with trisomy 21, which is medical terminology for Down syndrome. Question. Common symptom of patients with an atrial septal defect is cyanosis. What abnormality attributed to the disease aligns most with this symptom? Is it A, hyperplastic pulmonary artery? Is it B, defects in atrial and ventricular septums causing blood mixing, which is just mixing of oxygenated, deoxygenated blood? Is it overriding aorta, or is it one common valve? What do you guys think? Okay, I hear B. I hear B. Everyone agrees? B. Yes, it's B. It's an atrial and ventricular septal. And so, first off, what is, anyone know what the prefix hyper, what does that mean? If someone's hyperglycemic, what does that mean?
Too much.
Too much. And what about hypo?
Too little.
Too little. So in this case, hyperplastic pulmonary artery, what can you then associate with the pulmonary artery?
Too
Yeah, hyperexcited. Yeah, it's basically the pulmonary artery is overdeveloped, which I don't think that even happens. I mean, perhaps. I think, I don't know, I'll have to look into it. I know hypoplastic pulmonary artery happens where the pulmonary artery is not developed fully. But overriding aorta, that's something commonly in tetralogy I follow. And then one common valve, that's attributed to atrial septal defects, but it's not the most likely cause of this. So this is going to be an actual video, a surgical video. It's 12 minutes long, I believe, so you guys probably won't be able to finish it all. But this patient is an 11-year-old who is 38.8 kilograms, which is translates to 85.5 pounds. And this is a surgical video. Okay, there's going to be blood, gore, American Psycho, American Horror Story kind of stuff. So if you guys do not like blood, please look away. And this is also a website. If you guys are ever interested in CTS-NET, Cardiothoracic Surgery Network, this is where you can actually see open heart surgeries.
We present to you the repair of partial atrioventricular septal defect via a vertical right axillary thoracotomy in an 11-year-old child. This is an 11-year-old, 38.8 kilogram boy who was diagnosed with partial atrioventricular septal defect and has been followed clinically with minimal symptoms. Past medical and surgical history was significant for the need for surgery for a club feet and ADHD. Preoperative chest x-ray, posterior arterial and lateral views show cardiomegaly with increased pulmonary vascularity. Preoperative ECG shows sinus bradycardia with left axis deviation and a non-specific intraventricular conduction delay. For the next part of the video, and although it is not accurate, we will refer to the left and right atrioventricular valves as the mitral and the tricuspid valves respectively, and will refer to the zone of apposition of the left atrioventricular valve as the cleft in the anterior mitral valve leaflet. This is just for simplicity, but as we know, there are differences between these anatomical structures. Echocardiogram shows a large ostium primum atrial septal defect with a large left to right shunt. The defect measured about 2 centimeters. There is a cleft in the anterior leaflet of the mitral valve with mild to moderate degree of mitral valve regurgitation. The septal leaflet of the tricuspid valve appears to be tethered with mild tricuspid valve regurgitation. There is no ventricular level shunt. There is no additional atrial level shunting. There is a moderate degree of right atrial and right ventricular chamber enlargement with normal systolic function. The decision was made to proceed with surgical repair via a vertical right axillary thoracotomy through the fourth intercostal space. In these cases, the patient is positioned in the modified left lateral decubitus position with the right side up. And in addition to routine monitoring lines, An erector spinae block catheter is placed for postoperative pain management. The view in these operative photos is through the right atriotomy, and the mitral valve is seen through the large ostium primum atrioseptal defect. In the top two figures, the cleft is seen, and in the bottom figure, the cleft is closed and the valve appeared competent. The patient is positioned in the modified left lateral decubitus position with the right side up. A 6 centimeter vertical skin incision is made in the right mid-axillary line extending from the second to fifth ribs. The anterior border of the latissimus dorsi muscle is slightly mobilized to expose the underlying intercostal spaces. The right chest is entered through the right fourth intercostal space, and the right lung is retracted to expose the pericardium. The pericardium is longitudinally open 2 centimeters anterior to the right phrenic nerve, and stay sutures are placed. Heparin is then administered systemically. The ascending aorta is cannulated with an 18 French arterial cannula. The inferior and superior vena cava are cannulated with a 22 French and 20 French right-angled metal-tipped venous cannula respectively. Once ACT is satisfactory, cardiopulmonary bypass is initiated without difficulty at normal thermal. Both cava are encircled with snares. In ascending aorta, cardioplegia needle is then placed. The ascending aorta is cross-clamped and cardioplegic arrest is achieved in the standard fashion. An oblique right atriotomy is then made from the base of the right atrial appendage to the direction of the inferior vena cava cannula. Stay sutures are placed.
So now the heart is arrested, so you will not see it moving that much. That's because the patient's blood is being circulated
cardiac
on
anatomy
bypass.
is as described. The cleft in the mitral is identified. And is closed with multiple interrupted fibroproline sutures that are placed in a simple fashion.
Heart surgery is just sewing. So you see a lot of sutures, a lot of sewing stuff. If you
So
like
they're not-
sewing,
They're not adding any material here.
they are.
Oh, they
So
are.
I believe so. We'll have to see. I'm not sure.
Okay.
Can't remember.
The valve is tested and appears competent. After the mitral cleft has been closed, we turn to the atrioseptal defect.
Yes.
An appropriately sized bovine pericardial patch is then used to close the ostium primum atrioseptal defect.
So this
It
is
sewn
a
in
cow's
using running
pericardium
fibroproline sutures.
used.
So we mean pericardial membrane, right? So they take the membrane from outside the heart of the mouth
I believe so, yes.
and toss that in.
Yeah. I believe so.
That, I mean, that makes,
That makes sense, yeah.
yeah. It's so smooth.
Yeah.
In the area of the coronary sinus, the suture line is deviated to the left atrial side of the interatrial septum to avoid the conduction in tissue, thus leaving the coronary sinus draining on the right atrial side. The suture line is then transitioned back to the margin of the defect once we pass the coronary sinus. The Al-Salvo maneuver is then performed to rule out any residual shunts and de-air the left side of the heart.
So I know it's almost time to go to end. So thank you guys for this. Please feel free to contact me about any questions. This is my email as well as my LinkedIn. And yeah, thank you guys for allowing me to come talk to you. Best of luck in your future studies.
Chinese.